Now that you have heard the narration of our interesting case, let me give you a quick review about placental mesenchymal dysplasia. Placental mesenchymal dysplasia is a rare benign condition that is characterized by placentalomegaly and grape-like vesicles that can resemble a molar pregnancy on ultrasound and cross-placental examination. Incidence of this entity is markedly unknown. Most of the cases of PMD are diagnosed antenatally on ultrasound scans. Classic clinical picture of it is a thickened, enlarged placenta with hypoechoic spaces, typically giving the appearance of Swiss cheese, or also called moth-eaten placenta. Upon gross examination, here you can appreciate the fetal surface of the placenta has several multiple dilated chorionic plate vessels with areas of aneurysmal dilatation. The cut surface revealed numerous cystically dilated vesicles that were interspersed in between normal appearing parenchyma. These pictures of placenta are often misdiagnosed upon delivery as molar pregnancy. So what are the differential diagnoses of placentalomegaly? Whenever there is a diagnosis of placentalomegaly, please bear in mind these differential diagnoses. First is Beckwith-Wiedemann syndrome. 25% of cases of PMD are associated with Beckwith-Wiedemann syndrome. And mind you, BWS can present as only placentalomegaly, and hence an anomaly scan is recommended to rule out other differentials. The other differential diagnosis is a complete mole with co-twin or a partial mole. As you have seen in the ultrasound and upon gross examination, PMD can be easily confused with molar pregnancies, thus leading to early termination of pregnancy. But it is easy to diagnose molar gestation clinically and differentiate from PMD based on the tumor markers. In case of molar gestation, beta-HCG is markedly elevated, and there are several other clinical manifestations of the female. She may present as hyperemesis gravidarum, she may present with preeclampsia or new onset hypertension. She may also have abnormal thyroid hormones, thus presenting as thyroid storm. Doppler feature in the ultrasound shows typical glass-stained appearance with abundant blood flow in the dilated vessels. Confirmed diagnosis of molar gestation is anyways by genetic workup and histopathological analysis. The other differentials of PMD are that PMD can also occur as isolated placental mesenchymal dysplasia. This is diagnosed when the fetus is totally normal. Fetal prognosis is much better than a molar pregnancy in cases of isolated PMD. Often we see that fetuses with such diagnosis of isolated PMD may also present later in pregnancy as IUGR or IUFD. Why does this happen? We will explain in the next coming slide. Other differential to be kept in mind is chorioangioma. So what happens when once a patient is diagnosed with placental mesenchymal dysplasia? What are the consequences? The patient needs to be informed that she is at high risk of having preeclampsia. Her baby is at high risk of having intrauterine growth restriction, as 50% of cases of PMD are reported to be intrauterine growth restricted. The fetus can also have sudden death and result in a sudden IUFD due to prolonged hypoxia, secondary to fetal vascular obstructive pathology, which is characterized by chorionic thrombosis. Massive hemorrhage can also happen due to rupture of chorionic vessels, thus leading to sudden IUFD. Internal hemorrhage can also lead to maternal mortality and morbidity. So in conclusion, The patient must be very well counseled in regards to association of PMD with WBS and potential risk of prematurity, intrauterine growth restriction, preterm labor, preterm birth, intrauterine growth, and intrauterine fetal death. Most fetuses with PMD can develop normally without severe maternal complications. Hence, the differential diagnosis is crucial as PMD is most compatibly with a karyotypically normal fetus and thus results in a good maternal fetal outcome. Take-home message: it is of paramount importance to diagnose PMD antenatally in order to prevent early termination of pregnancy and to reduce associated morbidity and mortality. PMD must be included in the differential diagnosis in a normally appearing fetus with cystic appearance of the placenta. Sonographers and radiologists must be made aware about this entity in order to diagnose and include PMD in the differential so as to prevent early termination of pregnancy related to misdiagnosis of GTD or molar gestation. Patient must be well counseled about the increased risk of prematurity, preeclampsia, fetal loss, Beckwith-Wiedemann syndrome, and maternal morbidity. Patient with suspected isolated placental mesenchymal dysplasia in a normal fetus must be reassured about the possible good outcome. Pediatricians must also be made aware about this finding and its associations. Careful assessment of the fetus, including karyotyping, must be done to evaluate the possibility of gestational thromboplastic disease. However, placental histopathological examination is the cornerstone of the diagnosis of PMD. And finally, more studies are needed to establish true incidence, cause, and etiology of placental mesenchymal disease, and collaboration among obstetricians, radiologists, neonatologists, geneticists, and pathologists is fundamental. Thank you for your time. See you again.